Okay, so our patient is a 73-year-old male with a background of coronary artery disease. So many years ago, he had an extensive inferior wall myocardial infarction, and his most recent angiogram shows that he had a mid-RCA CTO and patent stents in the LAD. He also has a history of atrial fibrillation, diabetes, hyperthyroidism on treatment. And his symptoms primarily are that of dyspnea on exertion, NYHA functional class 3 to 4, congestive heart failure, volume overload. He's on guideline-directed medical therapy. And on his echocardiogram, we'll see shortly that he has severe massive ventricular functional tricuspid regurgitation of a tri-leaflet valve with an ER of 0.61 square centimeters. We will see that he has TR along the coaptation line, maximally at the center and posterior septal, with a systolic flow reversal in the hepatic veins. The right ventricle was dilated with some impairment of RV function. The left ventricular ejection fraction was about 45–50% with an old inferior infarction. Here we see a transthoracic and transesophageal imaging of the severity of the tricuspid regurgitation. We see the right ventricle with impaired contractility, tethering of the leaflets in the right ventricle, and dilatation of the right side, hepatic vein flow reversal, and a coaptation gap at the center of at least 7 millimeters. This is a 3D image of the tricuspid valve from mid-esophageal view position. We see that there is a significant coaptation gap that runs along the center and posterior septal part of the valve. I'm not sure if the pointer can highlight. Actually, the septal is up here, anterior is down here, and posterior is there. When we add color to this, we see that the color comes from the center and posterior septal areas. The next view to understand things is the transgastric view, where we see that we have a tri-leaflet valve, and we see that there is a significant coaptation gap at the center and slight at the anterior septal area here, and more so posterior septal. And if we add color to this, we see that we have color in a significant part of the valve. We have color coming anterior septal here, center and posterior septal along the coaptation zone. So a challenging case indeed, and here this sort of side-by-side view. In terms of feasibility, we saw this with in the intermediate in terms of feasibility because of the coaptation gap, because of the extent of the regurgitant jets. And in terms of the glide score, we assessed to be about 4, so an intermediate case for success. And with our procedure plan to be to put 2 devices, one device anterior septal close to the center, and a second device posterior septal in that area. And with this planning, we go ahead to decision of the what device to use. We opted to use the PASCAL ACE, which is a device that we commonly use for the tricuspid cases. And this is the view of the case itself. It took us a while to all this introduction, but it was important to highlight that we need to go in these cases in a planned way. We just don't go in to treat tricuspid regurgitation blindly. We will have to have a plan for a successful result. So here we have the introduction of the guide sheath into the right atrium, and here we have the first device. With our goal was to first go into an anterior septal position, being the traditional way of doing things, going anterior septal first. And here with multiplanar reconstructions, we have an assessment of our position and trajectories and our perpendicularity to the coaptation zone that we intend to go to. Here we also check the clasps, which one is the septal, which one is the lateral one. It's very important, as mentioned before, to have a good coaxiality to the valve plane and to be perpendicular to the coaptation zone that we're interested in. So we need to go more anteroseptal. in terms of our position. So we advanced with the device closed. We will advance into the right ventricle. And once we're below the leaflets, we will open the device. The beauty of multiplanar reconstruction is that you have all views at the same time, and you can quickly go to the 3D view and the short axis view to assess your clocking. This is the traditional transgastric view that we go to assess septal and anterior clocking. And here is our sequence of grasping in the grasping first the lateral leaflet and then the septal leaflet. So here is our position in the interseptal commissure with our first device. We're fairly deep in the septal commissure, and we're not really doing much to change the color of this valve. So with that, we changed our strategy at this point because our goal is always to get a good result with the initial device. If we don't get a good result, then we have to change our strategy. And because of the fact that there was a lot of color at the center and posterior of the valve, we changed our strategy to go with this device, more central posterior septal. So this is what we are doing at this point now. We changed completely our strategy, moving on to the center of the valve, and with our goal to grasp septal posterior first. As we couldn't really move this first device in a different position, we said, let's go for the posterior septal first, and then we'll go see what happens. So here we have, again, the same sequence of events. We assess our clocking on a transgastric view to be 3-9 configuration for this septal posterior part here. And here we go for independent clasping of leaflets again. First the lateral leaflet, the posterior leaflet, and then once we have that, we will move on to grasp the septal leaflet. Again, we assess our position, our clocking, very importantly, and now that we are verified our clocking is correct, we go for the septal leaflet independently. And we have a good leaflet capture there. Slowly closing the device. Assessing color, that we have a reduction of color as planned, as anticipated. And here we see in short axis that we have a good bringing together the septal and lateral leaflet in the intended area that we wanted to go. We need to assess, however, how much leaflet we have inside. So in this sense, we can open the device, keeping the clasps down, and assess whether the leaflets go all the way to the apex of the device or not. So here we open the device and we assess, we assess that we need to optimize the septal leaflet. And this is what we're doing here. And we also optimize the lateral leaflet as well. And closing again the device. Again, our position is septal posterior near the center of the valve. We assess the leaflet insertion with multiplanar reconstruction. Sometimes it's not always easy to see. So with MPR, we confirmed that we have enough septal leaflet inside and lateral leaflet as well. And with this, we went ahead to deploy this device as a first device in the center to septal posterior area of the valve. We do have significant color coming more anteriorly as we anticipated. And with that, we'll proceed with a second device. We see that we don't have any gradients. Gradient was less than 1. This is a nice 3D view that shows where we are now positioned in the septal posterior area. And we're going to put a second device in this anterior septal area as well. Showing the residual color at this point. So the second device comes in. This is a bicaval view in 3D, orienting now towards the valve. And again, biplane imaging for our position and trajectories. This one will move more in the interseptal area of the valve. Again, with MPR, we try to position our device as accurately as possible. We'll cross the device with the device closed into the right ventricle. And now we go again with independent clasping of the leaflets. We'll go first we'll check our orientation in our transgastric view. It's a typical 2-8 orientation in that area. And here we have clasping of the lateral leaflet. Yes.
Cordae.
Correct.
In the lower part, and that's why I think that area, although it looks okay, if you notice this cordae, this is a hint that you may have a problem to get the septal leaflet rightly and easily.
Yeah, that actually showed very well and didn't point it out in the transgastric short axis images that we had before. I can go back to that. And this is our final result, essentially, with the two devices. We know that we're going to have some regurgitation from the central part of the valve, which is very difficult to grasp in that area. There was a big coaptation gap. But overall, a moderate, mild to moderate residual TR. This is release of the second device here. And after release of the device, we will see the final result. Yeah. Now they're released. This is the 3D appearance of the two devices with some residual color between the devices, small residual color from the posterior septal area. Mean gradient was 2 millimeters of mercury. A very nice result and a very difficult anatomical substrate. And with that, just to summarize, this is the first device, how we clasp independently both leaflets in the posterior septal area. And then this is the second device, again, clasping independently both leaflets. This is the final result in 3D. And patient did very well, was discharged home on 3 days post. At the one month visit, the patient was doing fairly well. These are the images that we had at that point. And with that, I would like to thank you for your attention.
Thank you, Dr. Chrissoheris, for your work and for your nice presentation. I don't know if there are any questions, any from the moderators. We have, not time. It's already past the break as well.
If possible, can you put the PowerPoint back on the screen for 1 second? Just want to show what Dr. Spargis was commenting about in this transgastric view, that we have these cords attached to the septal leaflet that we know that we can't really go in this area here because the septal leaflet is a bit restricted. So we have to go in this part that doesn't have so much cords there. So this is you see these cords holding onto the septal leaflet. We know that this area is difficult to grasp in a sense. So thank you for that, yes.
So basically, this case was a little unconventional, the approach. It was a difficult case. It was, I would say, orange. You see color from everywhere. You see a large gap. And you see the cordae in the septal leaflet in the lower part. So usually when we go for two devices, we prefer the first device to go in the anteroseptal deeply and then come more to the center of the valve, like Vlas's case earlier. But in this case, we didn't really have an effect with the first device in the anteroseptal. And generally, our approach as a team is that we don't leave a device if we don't have a good reduction of the color. There's no point to leave a device just to leave it. Because then if you have a problem with the second device, you are left with no effect on the color. So we always go to have an effect on the regurgitation before we release the device. That's why we selected to go on the other side, which is a little unconventional, first more central, make sure that we reduce the color, and even if we failed with the second device, we would have some moderate reduction, and then we moved in the anteroseptal area to also add a reduction there.
Okay, I must thank once more Dr. Chrissoheris and all the speakers and the moderators, and then also the organizing committee.